Imagine this. You're in a room, packed with specialists, oncologists, surgeons, radiologists, pathologists, super sharp minds,
Mm,
and they're all laser focused on one thing, figuring out the absolute best path for a patient fighting cancer. That's a multidisciplinary cancer conference, an MCC.
yeah, it's intense. The sheer volume of information, the weight of the decisions, it's immense.
Absolutely. We're talking balancing potential success, the risks involved, the patient's whole life situation. It takes deep knowledge from everyone in that room.
Right. And for common cancers like urothelial carcinoma,
Yeah.
UC, and renal cell carcinoma, RCC, these make up, what, something like 26% of new diagnoses worldwide?
Yeah, big chunk.
The field is just constantly moving. New drugs, new research findings. It's incredibly hard to keep everything straight for every single patient.
It really is. And that constant change, plus the unique details of each person's case.
Well, there's a risk, right? Even for the best experts, maybe missing one small detail or misjudging a side effect.
Exactly. The complexity is just staggering. Which brings us neatly to our big question for this deep dive. Could AI actually help out here? Could it lend a hand in these super complex, very human decisions?
That's the focus. We're looking at a research paper detailing an AI system they developed specifically to support MCC decisions for UC and RCC.
So our mission today is to unpack this project. They called it KIT-2. We want to understand how they built it, what it actually does, how well it performed according to their tests, and this is crucial, how they made it explainable.
Right, we're giving you the shortcut to understanding this cutting-edge work where AI meets cancer care.
Okay, so let's really zoom in on the problem first. You mentioned the complexity, the need for different specialists.
Yeah, and it just keeps getting harder. Every new drug, every new trial adds another layer to consider.
So there's this constant pressure, this flood of information, plus every patient is different. The risk of overlooking something, even for experts, is always there.
It is, and that's where the paper suggests AI could step in. The idea is maybe an AI tool could help manage some of that complexity.
And potentially increase the level of evidence-based recommendations coming out of the MCC.
That's the goal. And it's interesting because AI has been used in oncology, for things like predicting survival or analyzing scans.
Right, image analysis and things like that.
But using AI to sift through complex patient text data and then actually suggest treatments, that's much less common territory.
So this KITTU project is really aiming at a very practical, maybe underserved application of AI in cancer care.
Precisely.
Okay, identifying the need is one thing. Building an AI that can handle these intricate cases and suggest treatments, that sounds incredibly challenging. How did they start?
Well, foundationally, it's about the data. They use real-world retrospective data collected between 2015 and 2022.
From actual patients.
Yes, patients over 18 with confirmed UC or RCC who had their cases discussed at the MCC at the University Medical Center Mainz in Germany.
And getting that data sounds like a huge job in itself. The paper mentions medical pros manually pulling out all the details, MCC notes, the final treatment recommendations, lots of patient background info.
Yeah, it wasn't automated. They had to extract it from the hospital systems, check it carefully for quality, make it anonymous for privacy, then transfer it securely.
And they gathered a ton of detail, right? Like 77 different factors for UC patients, 76 for RCC, which they then broke down even more for the AI.
That manual step is important. We'll circle back to why. But technically, their approach had a really smart innovation. They called it a significant technical advancement.
Ah, the two-step prediction? The
Yep.
divide and conquer thing?
Exactly. Instead of trying to make the AI predict the exact specific drug or surgery right away, which is super hard.
Because there are just so many options.
Way too many. So first, the AI predicts a high-level category. Think broad strokes,
Yeah.
surgery, anti-cancer drug, follow-up, that kind of thing. Then as a second step, if the high-level prediction is, say, anti-cancer drug, the AI predicts the specific low-level recommendation within that category, like maybe pembrolizumab or a specific chemo combo.
That makes sense. It breaks a really complex problem down into more manageable chunks for the AI. Smart.
Very. Another real-world complexity they had to tackle was that sometimes the MCC experts suggest multiple treatments that are basically equivalent options for the patient.
Right, not just one single best answer
Yeah.
sometimes.
So the AI needed to handle that, it's called multi-label prediction. But they had limited training data for some specific treatments, so they did something quite unique.
What was that?
They deliberately duplicated the patient cases where multiple options were given. So if a patient was recommended option A and option B, they essentially created two training examples for that patient, one labeled A and one labeled B.
Huh. So that effectively gave the AI more exposure to those less common but equally valid recommendations within their dataset size. Clever workaround.
It was. And then they trained a whole suite of different machine learning and deep learning algorithms on this prepared data, things like CatBoost, XGBoost, random forests, some deep learning models too.
Okay, so they built it, they trained it on real data using these clever techniques. How did it actually do? What were the results?
Performance was measured using F1 scores, which for listeners is kind of like accuracy, but it's better suited when your categories aren't balanced, like having way more surgery cases than best supportive care cases.
Right, common in medical data. Score goes from 0 to 1, higher is better.
Exactly. So for the UC cases, they had over 1,600 after that duplication trick.
Mm-hmm.
The best model for the high-level predictions, which turned out to be CatBoost, got an overall F1 score of about 0.70, so 70% basically.
Okay, 0.70 overall. How did it do on specific categories?
Pretty well on the common ones. Surgery hit an F1 of 0.81, and anti-cancer drug was even better at 0.83. But, as you'd expect, scores were lower for categories like best supportive care or follow-up. The researchers pointed out this was likely just due to having fewer examples of those cases to learn from.
Makes sense. What about the low-level predictions, the specific drugs for UC?
There, a model called XGBoost performed best, with an overall F1 around 0.73. And it did really well on some specific common treatments like the gemcitabine platinum chemotherapy combination. That was 0.88. Pembrolizumab was 0.70. Pretty solid.
Okay, so decent performance for UC. What about RCC, the kidney cancer cases?
For RCC, they had fewer cases, around 880 after duplication. Again, CatBoost was the winner for high-level predictions, scoring even better here with an overall F1 of 0.76.
Oh, higher than UC.
Yeah. And some key categories were very strong. Anti-cancer drug recommendations hit 0.92 F1. Follow-up was 0.88. Really good.
Wow. And the specific drugs for RCC, the low-level predictions?
XGBoost again led the pack with an overall F1 of 0.68. Now, interestingly, they reported perfect F1 scores, 1.00 for two drugs, pazopanib and pembrolizumab.
A perfect score.
Well, the paper notes, and is detailed more in the supplement, that this can sometimes happen when the number of test cases for those specific drugs is very small. It means the model got every single one right in that small test set.
Ah, okay. So impressive, but maybe needs a grain of salt until tested on more data for those specific drugs.
Precisely. It shows promise, but you need more validation for a definitive 1.0 score. And similar to UC, the really rare low-level treatments in RCC were grouped into an other category for now.
Got it. So the performance looks promising, especially for the more common recommendations. But you mentioned something crucial earlier, explainability.
Yes, this is absolutely key in medicine. You can't just have a black box spitting out recommendations. Doctors need to understand why the AI is suggesting something.
Right, for trust, for clinical validation.
Totally. And this key ITGU system has what they call a unique explainability component. They used a method called SHAP.
SHAP, how does that work? What does it show the doctor?
Basically, SHAP helps pinpoint which specific patient features were most important or relevant in driving the AI's prediction.
Okay.
It works on two levels. For one single patient, SHAP can create a visual that shows how much each of their characteristics, like, say, their age being 75, or their cancer stage being the third, or a specific lab value, push the AI's prediction probability up or down for a certain recommendation.
So if the AI says recommend anti-cancer drug with 85% probability, SHAP can show which of that patient's details made the AI lean so strongly that way.
Exactly. It breaks down the contribution of each factor. Super valuable for the clinician.
That really helps lift the lid on the AI's reasoning. What about the other level? You said two levels.
Right, the global explanation. SHAP can also give a bigger picture view. For example, it can analyze all of the patients who were recommended anti-cancer drugs for UC and show which features were generally the most important drivers for that recommendation across the board.
Ah, so it highlights the key factors overall for that treatment class.
Yes. And it can show trends, like maybe higher tumor stages consistently push towards that recommendation, while lower stages push away. The paper mentions things like UICC stage, the treatment line number, and age being key global factors for the anti-cancer drug class in UC.
That's incredibly useful context, and I saw they also integrated survival data from clinical trials into this whole system.
They did. That adds another layer of evidence to potentially support the recommendations and enhance the explanations.
Okay, so you have this AI making predictions and this SHOP method explaining why. How does a doctor actually use this in practice?
They build an interactive dashboard. Think of it as the user interface for the medical team.
Makes sense. What does it show?
It presents the AI suggestions, both the high-level category and the specific low-level ones, probably highlighting the top predictions. And crucially, it displays those SHAP visualizations right alongside.
So the doctor sees the recommendation and the explanation based on that specific patient's data and relevant trial info all in one place.
Exactly. It puts the AI's output into context.
But, and this seems vital, the paper stresses that the AI is a support tool, right?
Absolutely critical point. They state very clearly, final treatment decisions will always be made by humans. The AI provides information, suggestions, explanations, but the expert MCC panel makes the call.
Which seems like the right balance. So looking
Yeah.
at the whole picture, what makes this study really stand out?
Well, the researchers position it as the first explainable AI tool designed specifically for MCC recommendations in UC and RCC. That's a claim to novelty right there.
And beyond being first, what are the strengths and how they did it?
Several things. One is using that complex tabular patient data, all those different parameters. That's not like feeding images into a pre-trained model. It required custom development and a lot of careful data handling.
Right, it's messy, real-world clinical data.
Exactly. Another strength is the scope, including patients at all stages of the disease, from localized to metastatic, and across all treatment lines. Some previous AI work in oncology focused more narrowly, maybe just on early-stage prostate cancer, with fewer treatment options to predict.
And bringing in so many patient variables, those 77 or 76 factors, without prejudging which ones were important, letting the AI find the patterns.
Yes, aiming for an unbiased approach by using comprehensive data. Plus, the combination of achieving pretty good accuracy and baking in that explainability component right from the start is a major advantage.
And their technical solutions, like the two-stage prediction and the data duplication trick for handling multiple recommendations, seem like smart ways to deal with the specific challenges of this data set.
Definitely innovative adaptations.
Yeah.
And that explainability piece just keeps coming up because it's so foundational for getting doctors to trust and actually use these kinds of tools.
Makes total sense. Now, no study is perfect. What limitations did they acknowledge?
They were upfront about several. It's a single-center study. All data came from one hospital in Mainz. So you need to see if the system works as well in other hospitals with potentially different patient populations or data practices.
Okay, generalizability needs testing.
And it's retrospective, meaning it looked back at past data. A prospective study, using it on current or future patients, is the gold standard for proving clinical utility.
Right. What about that data extraction point you mentioned earlier?
Ah, yes, the bottleneck. Right now, the high quality of their results depends on that very time-consuming manual data extraction by medical professionals.
Because automated methods aren't good enough yet.
Apparently not. They specifically mention that using things like current large language models for automated extraction doesn't yet provide sufficient quality. They cited issues like inaccuracies, hallucinations, the AI making things up, and just the sheer computer power needed. So manual effort is still necessary for this level of quality, which is a practical hurdle.
That's a significant limitation for scaling this up. Any other limitations?
Just the other category we discussed. Having to lump together very rare specific treatments because of low case numbers, it limits the granularity for those less common options in this first version.
Understood. So acknowledging those limitations, what's next for this KITU system?
The paper explicitly states the mandatory next step is a prospective study, testing it in a forward-looking way to gather stronger evidence.
Makes sense. Are they planning to expand it beyond UC and RCC?
Yes. The plan is to tackle prostate cancer next, building on their urological oncology base, and then potentially branch out to other types of cancer later on once the foundation is really solid.
Okay. So wrapping this up, what's the big takeaway from our deep dive into this paper?
I think it really demonstrates that building an explainable AI system to support these incredibly complex cancer treatment decisions is feasible. For UC and RCC, they showed it can be done with, pretty high clinical quality based on their metrics.
It feels like a significant contribution, pushing the boundaries of evidence-based, AI-assisted cancer care.
It really does. The authors frame it as pioneering future work and potentially setting a standard for how these kinds of clinical decision support tools should be developed globally, especially that focus on explainability.
It definitely leaves you thinking, doesn't it? How might tools like this change the actual dynamic in that MCC room in the future? Could the AI become almost like another expert voice at the table, offering this incredibly broad, data-driven perspective?
Or perhaps the bigger question remains, how do we solve that fundamental challenge of getting enough high-quality structured data out of our complex healthcare systems to truly power and validate these incredibly promising AI tools on a wider scale? That data bottleneck feels like a major hurdle still.